I've got everybody else accounted for. Okay. Well, we'll go ahead and get started. It's 8:30. Okay, excellent. So before we get going into the topics that I want to talk about today, we're going to focus on cell response to stress, cellular adaptation. We're going to talk about shock. We're going to talk about necrosis and apoptosis as well. But I wanted to go ahead and talk a little bit about all the homework that was due. I have started grading that. I have a lot of the chapter summaries due, or a lot of the chapter summaries I have graded, and I've started on some of the homework as well. So I'll continue to get all of those grades done over the next week. Try to stay caught up there. So without, let's see here, there is no other housekeeping that we need to do other than just talk about homework. So let me just open the floor real quick. I do note a couple people logged in during open office hours yesterday with a few questions about homework. Hopefully I answered things okay there. Are there any questions about the homework since I have everybody here?
Yeah, Chris, I had a question about I guess it was the advanced acid-base worksheet, and it was question 4. I kind of went over it, and then the last part of that was what is the hydrogen ion concentration? I didn't really understand how to get that, but
excellent. No, that was I think that was the most common question I had yesterday as well, was regarding that. So let's go ahead and actually work through that. So let me just log in with the iPad so I can throw that up. I think that was the most common question, that, and there are a couple questions about the anion gap. So far, it doesn't look like anybody is having issues with the ABG interpretation. I haven't graded everything, but the ones I've looked at so far, nobody has struggled on that, so that looks good. So let me just go ahead and get logged in here through the iPad, and we'll talk about that specific one. Just 'cause I think that's a good question. So I just pulled up the whiteboard here. So let me go to that specific question, just because we'll need to pull some numbers out of that. So that is advanced acid base. This is like question 4, part 3, or let me find it exactly. Case 4, question 3. Yeah. So it says he has a non-anion gap metabolic acidosis. That's actually false. The anion gap's elevated. But then the second part, what is the hydrogen ion concentration? So what is the hydrogen ion concentration? So let's go ahead and let's talk about that. So first of all, let me just ask the question, what is pH? What is pH?
Potential hydrogen. It's measuring the hydrogen.
So pH is the power of hydrogen or the potential of hydrogen. But what is it? How do we actually get the pH? What does it equal?
The negative log to the 10th.
Good. Negative log base 10 of what, though?
The hydrogen ion.
Awesome. So pH equals negative log base 10 of the hydrogen ion concentration. So essentially what this question is asking is saying, hey, you have the pH. How can I convert pH into hydrogen ion concentration in molar concentration of hydrogen ions. So that's really all it's asking. So let's see if we can kind of figure out how that's done, and we will see what we can get. So so if we rearrange this, so I want to put hydrogen ions on one side, rather. I want to move the hydrogen ion concentration H plus equals. And in this case, what I want to do is I want to bring this 10 down, right? So equals 10 to the minus, I'll move this minus over here, 10 to the minus pH. All right, so that's mathematically how we could do that. So what you can do is you can just go online and find a calculator to do this for you. And I just, in no particular endorsement, I'm going to go ahead and just share a calculator with you all real quickly here. And I'll show you how it works. And then we'll do some additional math to make sure that we're confident that the answer we get actually works. So let me see. I wish it would let me share multiple things at the same time. That would be nice. But I'm going to have to stop sharing the whiteboard. And instead, I'm going to go here. So you can see these formula here. So pH equals the negative log of the molar concentration of hydrogen ions. We agree there. And so we just rearranged to solve for hydrogen ion concentration. That's 10 to the minus pH. So what I'm going to do here is I am going to put the pH of the patient in, and I'm just using carbonic acid, since carbonic acid is the primary volatile acid that we're dealing with in the human being. And I believe the pH was 7.3. But let me go 7.35. Okay, I was going to go back and just verify it. So 7.35. All right. So we now converted that. The hydrogen ion concentration is 0.0000000467 molar, right? So if we convert that into scientific notation, how many times do I have to move this decimal point to the right to get to 4? So I have to move this decimal point 1, 2, 3, 4, 5, 6, 7, 8 times, looks like. All right. And I'm just going to do it on the board here. 1, 2, maybe 1, 2, 3, 4, 5, 6, 7, 8. All right, 8 times. Good. All right. And that would give me -8. All right. So far, so good. Okay. Oh, hold on here. Let me get Matthew admitted in. There we go. All right. So we just did the calculation. Again, I just let the calculator do it. So pH of 7.35 is this in molar. This would be moles per liter concentration. So again, you can see why pH is just a much more convenient measure for measuring hydrogen ion concentration. So then what we can do is we can just double check our work here. All right, so I've just pulled up a negative logarithm calculator. Make sure everybody can see that. There we go. All right. So then I put in that 0.0000000, right? And I just rounded it to 4.5 instead of 4.4 and some change. I just rounded it to 0.45. And then we're going to go negative log base 10. And then what I'm going to do is I'm going to hit calculate. And this should give me the pH back, right? If pH is the negative logarithm of the molar concentration, then if I take the negative logarithm of that molar concentration, I should get that original pH back. So I'm just going to hit calculate. And there you go, 7.346. But because I rounded, it's a little off, but we can round that up to 7.35. And that gives us back the original pH. So the math does, in fact, work out there. So any questions over that, over what's going on there? Is everybody okay?
Yep, got it. Thanks.
Yeah, no problem. The other question that came up was about anion gap. There are, I think the question was on the lines of there are several ways, or there are not several, but there are a couple of different ways you can calculate the anion gap, which is true. So there are some formulas that do not take potassium into consideration because potassium tends to be a fairly small number. And so they just use the sodium by itself, which is okay for the most part. Now, if you have underlying hyperkalemia and your serum potassium is very high, that may be problematic. So I just tend to use add sodium and potassium and then just plus or minus 4, right? So we said the normal value for anion gap is 12 plus or minus 4. And that kind of takes into account that wiggle room for potassium. But there are some other ways of doing it that are fairly legitimate. Now, with that in mind, I did want to mention a couple of things about potassium and sodium and calcium specifically. And this is a good segue into that. And so let me go ahead and share this with you all. All right. The notes here. And this is something that's important in the setting of acidosis. So in acidosis, some of the things that can happen when you have an increase in hydrogen ion concentration, remember those hydrogen ions are positively charged. And sometimes what can happen is hydrogen ions can shift into the cells and they can bind to or associate with proteins in the cells. And so what can happen is as positive charge is moving into the cell, positive charge kind of needs to move out in a way, because remember, positives and negatives repel each other. And so what can happen is in the setting of acidosis is you can get potassium ions shifting out of the cells. And so what will happen is your serum potassium levels will increase and you will have something known as a relative hyperkalemia, where the serum potassium will be elevated, but the overall potassium isn't actually elevated, because what will happen is as you treat that acidosis and the hydrogen ion concentration decreases, potassium shift back into the cells, right? And when that happens, the potassium levels will go down and everything will be okay. Or in some cases, as that potassium shifts back in the cell, you'll actually have a lowering of the potassium and you will actually have a hypokalemia. You'll have a hypokalemia. And we see this in the setting of certain hyperosmolar states, such as DKA is a classic problem where we see it. So somebody's in diabetic ketoacidosis. So what happens is their pH gets very low, and then that causes potassium ions to shift out of cells. And so their potassium is increased. But what happens is as we start treating the diabetic ketoacidosis with fluids and typically insulin a little later on, what will happen is their potassium levels will begin to shift and the potassium levels will drop. And because DKA patients are urinating a lot, because their kidneys are trying to get rid of the excess glucose, they tend to be dehydrated and they tend to pee out a lot of potassium ions. And so their overall potassium it can be very low. So it is not uncommon to see a patient with DKA or some other condition that causes a notable metabolic acidosis to see them receiving potassium. And then you look at the labs and you go, wait a minute, they're hyperkalemic. Why are they getting potassium? The reason they're getting potassium supplement is because their overall potassium levels are low. And as the acidosis gets treated, right, the underlying conditions causing acidosis gets treated, they will have a shift in their potassium and they may very well be overall hypokalemic. So just like all the other technologies that we have out here, you can't just solely rely on lab values to make clinical decisions, right? So it kind of goes back to the whole mantra of treat the patient, not the monitor. Well, the same thing applies with some of these labs, right? So you always have to ask yourself, why is a lab high or low? And what is the underlying reasoning there? And what's the clinical reasoning for doing what we're doing? But with that in mind, let's just spend a few minutes talking about hyperkalemia. Of course, you had the fluid and electrolyte videos that I assigned for you to watch. But what is a major problem with hyperkalemia? Or let's just talk about potassium imbalance in general. If my potassium gets too high or too low, and remember 3.5 to 5 is more or less the normal range, what is a major primary problem with potassium imbalances in general? What's the general problem?
Cardiac conduction.
Good, yeah. So cardiac conduction issues. Yeah, cardiac conduction. Specifically when it comes to repolarization, right? And we'll talk about this in a lot more detail in ECG interpretation. But yeah, cardiac conduction. So when you have potassium that is too low, or let's start off with too high, because that's one of the classic electrolyte problems we run into. All right. So what tends to happen in hyperkalemia, if you look at, and everybody knows what a PQRST complex looks like. I'll just draw it there for you all. All right, so you've got the P wave, the QRS complex, and the T wave. And remember, the P wave is atrial depolarization. The QRS complex is ventricular depolarization, and then the T wave is ventricular repolarization. So in the setting of hyperkalemia, let me turn my video off. It looks like I'm getting some audio issues here. There we go. So in the setting of hyperkalemia, what we tend to see is T-wave anomalies, right? Because we said that this is primarily a repolarization problem. And so the primary thing that you see is the development of tall, peaked T waves. So this is a classic finding that we see with hyperkalemia. And then what tends to happen is the T waves become flattened out, and then the QRSs can widen as the hyperkalemia gets more severe. And then in the most severe cases, what happens is you have a complete loss of P waves, and the QRS complex and the T wave kind of merges in to each other, and you develop what's called a sine wave. And it's just this wide, complex rhythm that develops. And these patients, of course, are at high risk for developing cardiac arrest, ventricular tachycardia, ventricular fibrillation. And these cardiac arrest rhythms will not respond to standard therapies very well. So with that in mind, can you all tell me some causes of hyperkalemia? What are some major causes of hyperkalemia?
Renal failure.
Good. Renal failure is a big one, because one of the only way we get rid of potassium ions is through the renal system. So hyperkalemia is common renal failure, and it's common in patients who have missed dialysis. What are some other causes?
People taking too much Tums, antacids.
So Tums typically contain like calcium carbonate, sodium bicarbonate. But there are some potassium supplements out there. And there are some things that contain potassium. So it is possible to overdose on potassium supplements. It's not as common. It's not a super common cause, but it certainly can happen. What are some other causes?
What about the use of ACE inhibitors?
ACE inhibitors can be associated with ACE inhibitors, and there are categories of diuretics called potassium sparing diuretics. These are diuretics that actually prevent us from losing potassium. So if you have someone who's not peeing a whole lot and they're getting a potassium sparing diuretic, or possibly an ACE inhibitor, it is possible that that can precipitate hyperkalemia. What else?
Massive burns.
Yeah, so specific traumatic injuries, specifically large burns. And I want you also to think of electrical injuries, which tend to create burns as current transfers energy into the body. And in addition to that, I want you also to think of crush trauma. If you have a substantial crush injury. And another kind of problem known as rhabdomyolysis. And does anyone know what rhabdomyolysis is?
Stephen does.
I believe Steve does.
Hey, that's hurtful, man.
Too soon.
I think Stephen knows the answer.
Yeah. What is rhabdo? It's pretty common.
Buildup of lactic acid.
Well, say that again.
It's whenever your body like starts to break down and try to digest muscle enzymes.
Specifically, yeah, it's any condition that causes muscle breakdown. If you have large amounts of muscle breakdown, and there are actually several things that can cause rhabdomyolysis. Right, so heat injuries, for example, can cause it. Heat stroke, hypothermia, for example. Trauma can cause it. excessive strength training, working out, excessive physical activity can cause it as well. So there are actually several reasons that, or several things that can cause rapid. So essentially, these are all things that, with the exception of renal failure, potassium supplements, and possibly diuretics, these are all things that cause a release of potassium ions. So most of the potassium in your body is within the cells. So whenever you have a large release of potassium, or in these cases, you're not able to get rid of potassium, or you're gaining it faster than you're losing it, then you can develop hyperkalemia. And so what is the treatment for hyperkalemia?
You can't get PTSD when you like to kill. That's like me having flashbacks to
PTSD is not a
Chinese
treatment for
buffet in
hyperkalemia.
1992. I was in Iraq in 2003, and we were there. We were the first
Somebody's
US
mic's
soldiers
on.
we were in, and I mean, I didn't see anybody sleeping in bombs.
Stabilize the cells would be the first thing, that calcium.
Yeah, so let's talk about this. So yeah, it's a 3-step process. Okay, so step 1 is buy yourself time. All right, that's step 1, buy yourself time. And you buy yourself time by stabilizing the myocardial cell membrane. And as you mentioned, calcium can do that, either calcium gluconate or calcium chloride. Either or works. Calcium chloride tends to give you more elemental calcium available. That's step 1, and that buys you about 45 minutes or so. And then step 2 is to shift potassium ions back into the cell. And we can actually do this as paramedics, and there are several things that will do this. First of all, albuterol will do this, right? Remember, one of the side effects of albuterol is hypokalemia. So give albuterol, typically large doses, like 10 to 20 milligrams of albuterol over an hour or so, right? So we're going to give very large doses of albuterol. We can make the patient more alkalotic, right? Because acidosis causes an extracellular shift. Alkalosis can cause an intracellular shift. So giving sodium bicarbonate, this is actually one of the very few instances where sodium bicarbonate is actually recommended in the treatment of a life-threatening hyperkalemia. And typically we would give a 1 milli equivalent per kilogram dose of sodium bicarbonate. Other things that can do this, insulin. Giving patients insulin can do this as well. And so insulin and dextrose therapy in the hospital is commonly used. And then the third and the definitive way of treating it is actually eliminating the potassium from the body. And that tends to be dialysis. Emergency dialysis, obviously we can't do that, but a lot of this we can do. We can initiate that treatment. So that's life-threatening hyperkalemia. Hypokalemia tends to present a little differently. As far as the ECG goes, what happens is you kind of have the opposite. You have tall peaked P waves with depressed T waves. With hypokalemia, and you can just get general signs and symptoms of weakness, malaise, and just real non-specific. In both cases of hyper and hypokalemia, the constitutional or the general signs and symptoms are fairly non-specific: weakness, not feeling well, malaise, etc. So a lot of it comes down to what is the patient's history. right? What is a history? Do they have a history of some issue that is associated with life-threatening potassium imbalances? And do electrocardiographic findings support that? Now, you do not necessarily see these ECG findings in all cases of life-threatening potassium imbalances. So that does make the case a little more confusing sometimes. But when you have a lot of the classical things line up, that's something to think about. All right. So that's potassium. The other major issue that we run into is sodium imbalances. All right. And they're just like potassium, there are two major sodium balances. There's hypernatremia and hyponatremia. And hypernatremia is essentially too much sodium, which is not as common as hyponatremia. So I'm not going to spend quite as much time talking about hypernatremia. I know that we talked about it a bit in the video assignments, but you know, hypernatremia is where your serum sodium gets too high, it's too elevated, and that can sometimes occur in the setting of heart failure, in the setting of certain kinds of dehydration as well, where you're losing fluid but retaining sodium, in some renal issues. But it's not nearly as common as hyponatremia. So I just want to spend a little more time talking about hyponatremia because it is more common and it's actually very complicated. All right. So let's talk about hyponatremia real quick. So this is where the serum sodium is less than 135. Remember, 135 to 145 is normal serum sodium. All right. So if we have hyponatremia, all right, so you see the patient's sodium and it's less than 135, what we need to do is we need to figure out what kind of hyponatremia we're dealing with, right? What is the osmolality of the patient's serum? So we need to calculate the serum osmolality, right? That's what we need to get this first to figure out what kind of hyponatremia are we dealing with. How do we figure that out? Well, there are calculators out there, but the formula is as follows: 2 times the patient's sodium level plus their glucose divided by 18 plus their blood urea nitrogen divided by 2.8. And that will give you their osmolality, or very, very close calculated osmolality. All right. And so what you're going to do is you're going to calculate their osmolality, and then you're going to look at the measured osmolality. What does the lab actually measure, right? And if the measured is much higher than the calculated, all right? So the measured is much higher than calculated. You want to think some sort of toxic ingestion. There's some sort of toxic ingestion going on. All right. Those are the differentials: ethylene glycol, methanol, things of that nature. All right. Another thing that you need to be aware of, another pitfall, is that glucose. All right. Glucose, when it gets elevated, can cause a false hyponatremia. So if the patient is hyponatremic and their blood sugar is elevated, you will need to take that into consideration. All right. And essentially what happens is, for every 100 milligrams per deciliter of glucose over 100, we need to add 1.6 milliequivalents to what the measured sodium is. So for example, let's say I have a patient and they have a sodium of 130, all right, which is technically hyponatremic. And then their glucose is 600, right? So that means that they are 500 over 100, right? And so what we need to do is they are 5 times over 100. So what I do is I do 5 multiplied by 1.6, and that equals 8. So I need to add that to the sodium, and that gives me a sodium of 130 milliequivalents per liter. So their sodium is in fact not low. It is a false, there is a falsely low reading on the lab. All right. So you have hyponatremia, calculate the serum osmolality, compare it to the measured. The measured's a lot higher, think toxic ingestion, and then look at the patient's glucose. And if the glucose is over 100, right, then you need to take that into account and make sure that it is not a hyperglycemia that is causing a falsely low sodium. Once we get that out of the way, and we've established that this is a legitimate hyponatremia, then we can ask, well, what kind of hyponatremia is it? All right. And so, is the patient's osmolality elevated? So they're hyponatremic, but the osmolality is elevated. That means that their blood is hypertonic compared to the cells. And so this is a hypertonic hyponatremia. All right. And hypertonic hyponatremia tends to be caused by this stuff here. Right? Their sodium's low, their blood is very hypertonic because there's something else in their blood that is causing it to be hypertonic. Typically, that's going to be glucose, or that's going to be the ingestion of some sort of toxic alcohol like methanol or ethylene glycol, right? So think of severe hyperglycemia and think of toxic alcohols. All right. Now, if they are hypotonic, all right, so they're measured is low, the osmolality is low, then you think hypotonic. All right. And typically what these patients need is fluid. All right. Good old normal saline, for example, is fine for most of these patients. All right. And then there's another category called, oops, let me sorry about that. There we go. So most of the time, hypotonic, they need fluids. All right. Or that's generally where we're going to start as pre-hospital providers. Now, there are two kind of categories under the hypotonic. All right. And this has to do with the volume status of the patient. And I should say, I'll just point this out. There is also something called isotonic hyponatremia, where the serum osmolality is normal. And this tends to be a false reading. This tends to just be caused by excessive fat and excessive protein content in the blood. So if somebody has super high lipids, right? The triglycerides are super high, or the lipids are super high, that can cause false, right? So that tends to be kind of falsely low. So hypertonic and hypotonic are the situations where we need treatment. And if it's hypertonic, the treatment's going to be focused on if it's an underlying toxic alcohol, we treat that, or if they're really hyperglycemic, well, we treat that. And then hypotonic, there are two kind of subcategories of hypotonic, and this has to do with the fluid volume status of the patient. There are really three, but let's start with the first one is, are they fluid overloaded? And this is hypervolemic. Are they fluid overloaded? And if they're fluid overloaded and their sodium is low, all right, obviously we need to restrict water. All right, we want to restrict water. All right. If they are euvolemic, restrict water, and then diuresis, get rid of that water, that excess water. And this tends to be common with like congestive heart failure, where you have a buildup of fluid, and renal failure. Again, because you can't get rid of fluid, and so you're diluting out your sodium. All right. So your sodium's low and your fluid volume status is low. Fluids for the win here. All right. Fluid for the win. And then there's also something called euvolemic, where the volume status is generally going to be okay. And we treat it similar to hypervolemic, and you want to restrict water. All right. Sometimes this is referred to as dilutional. Sodium is diluted out. All right. We used to run into this with something like MDMA. It's kind of a classic thing that can cause this. Sometimes referred to as ecstasy by its street name. One of the things it can do is it can cause you to retain water. You can dilute out your sodium. You can have a delusional hyponatremia. And sometimes we see this in people that just drink lots of water as well, drink excessive amounts of water. They dilute out their sodium. They have a delusional hyponatremia. In fact, a few years ago, a lady died during a radio show. It was called P for a Wee. And essentially what it was people would drink massive amounts of water, and they would not urinate. They would forestall urination, and whoever could hold their pee in the longest would win some game console, presumably called a Wii. And a lady ended up drinking, I think it was over a gallon of water in a very short amount of time, didn't urinate, ended up having seizures on set, on the radio set, had a seizure. She was transported to the hospital, ended up dying of cerebral edema due to delusional hyponatremia. So these things do occasionally happen. And again, that's a problem with sodium, right? We said that potassium impacts the heart and sodium impacts the brain. And hyponatremia, what we're really concerned about with life-threatening hyponatremia is cerebral edema, because if the blood becomes hypotonic compared to the cells, this sets you up for cerebral edema in particular, as the cells begin taking on water. All right. Some other things that can cause this, in addition to more esoteric things like MDMA and drinking too much water, we call water toxicity. I want you to think of the term RAAS. These are some of the other differentials. So the first one is renal tubular acidosis. We mentioned that last week. Addison's disease, This is a disease where their adrenal glands do not secrete glucose and mineralocorticoids, and so they have difficulty regulating fluid and electrolyte balance. One of many problems that do with Addison's, particularly Addison's crisis. Think of thyroid disorders, specifically hyperthyroidism or Graves' disease, and then a condition called SIADH, which is kind of the classic condition that we see causing this, and that stands for Syndrome of Inappropriate Antidiuretic Hormone. So SIADH is where someone has too much antidiuretic hormone. ADH is also referred to as vasopressin. And one of the things the antidiuretic hormone does is it causes you to hold on to water, causes you to retain water, then you can dilute out the sodium and you get a dilutional hyponatremia. And we see this in people with certain cancers and tumors. There's signs of lung cancer, small or oat cell carcinoma, for example, can secrete this. We see the tumors of the pituitary gland, and we can see this in head injuries as well, right? In addition to that, severe hyponatremia is relatively common in people that are septic, have sepsis and septic shock. So it's another thing you want to think about. All right. So SIDH and sepsis. So those are some of the other major differentials. So that is hyponatremia. So typically we treat it by either restricting water or adding sodium. And in severe cases, right, we may even need to give hypertonic saline if the patient is having seizures. But what is a big problem with correcting sodium in particular? And we see this not only with sodium, but we can also see this with glucose. So if we correct sodium and glucose too rapidly, what is one of the major problems we can run into?
The osmotic demyelination syndrome.
Awesome. Osmotic demyelination syndrome. Some people refer to this as central pontine demyelinating syndrome. Essentially what happens is you overcorrect the sodium or the glucose in some cases, and you can cause rapid shifts of water. And as water shifts into and out of different cellular compartments, specifically nervous tissue, you can essentially blow the myelin off of the neurons, right? So you can cause marked demyelination of neurons, and that can result in a devastating neurological injury. People can have a sustained loss of consciousness. They can go into a sustained vegetative state, right? I mean, this can be utterly devastating neurologically to these people, and it is an absolute life-threatening, devastating injury that is caused by us, right? This is an injury that we cause, that healthcare providers cause. Sometimes is referred to as an iatrogenic. An iatrogenic. Whenever something is iatrogenic, that means it is provider caused. Iatrogenic injury. And this is one of those. It's fairly rare, luckily, but if it does happen, it is incredibly nasty. So the general rule of thumb is never change sodium by more than 1 milliequivalent per liter per hour. All right, so our goal, if we're correcting sodium, if we want to increase it, is by about 0.5 milliequivalents per liter per hour. All right. Typically for pre-hospital purposes, giving somebody normal saline, remember normal saline has 154 milliequivalents of sodium per liter, right? Just giving normal saline, it generally is plenty enough treatment for our purposes for the most part. All right. So that's sodium and potassium. I just wanted to spend a little extra time talking about those. The other thing I wanted to mention, we talked about this last week, calcium. There is a relationship that calcium has with albumin. And so what can happen is albumin imbalances can cause a false interpretation of what we see with calcium, right? So if the patient has hypoalbuminemia, so they have a low albumin, okay, they may in fact have a normal calcium. So we just need to correct for that. So when you look at somebody's calcium, you always want to think correct for albumin. And typically calcium is measured in milligrams per deciliter, unlike other electrolytes. And the normal value is about 9 to 10.5 milligrams per deciliter. All right. And just for reference, a normal albumin is 3.5 to 5.5 grams per deciliter, or 35 to 55 grams per liter, right in there. All right. So what I would recommend you do is just use a calculator. There are plenty out there. I'm just going to show you one specific calculator here. And I've just got to get out of the iPad here, and then I'll run into screen share with you all here. All right. So give me a minute. Maybe it's going to share. Come on. There we go. We got something going. There we go. Okay. So this is just a calculator for correcting calcium. So let's just say we draw calcium and it's 10. And we're just going to go with 4 as our normal. And then we notice the patient has an albumin of 2. All right. So you can see what that did is that increased their potassium to 11.6, right? In addition to that, let's just drop their albumin even more, 12.4, 0.5, right? 12.8, right? So you can see that relationship with low albumin. All right. And how that albumin can kind of cause a falsely elevated potassium or calcium. So if the albumin is very low, then what we'll need to do is we'll just need to order an ionized calcium level, like figure out, okay, how much calcium ions do they actually have in their blood? And that will kind of help things out there. So if there's an albumin problem, there you go. Okay, so I think that's all I want to talk about there as far as some of the stuff from last week. We're coming up on the first hour. So are there any questions before we take our first break? Anybody have any questions? All right, 9:25. What you got?
So, just going back to when you were calculating the overall sodium, and with the glucose, and you're talking about, I guess when you were talking about adding the milligrams of sodium to the elevated glucose, is that after you did the calculation, or is that the measured?
No, so what you're going to do is, so you're going to look at the lab, the measured sodium. And like the example I gave you was 130, right? The measured was 130, it was low, right? And then you look over at their measured glucose and you notice 600 and you go, oh, wait a minute, that's 5 times what it should be, right? Because it's right at about 100, right, is more or less normal, right? And so it is 5 times over 100, 5 times the normal. And so what we need to do is we need to add 1.6 milliequivalents per liter of sodium for every 100 milligrams per deciliter of glucose above 100, right? So at 600, that's 100, 200, 300, 400, 500, 600, 5 times. So that's 5 times 1.6 gives us 8. And then I add that 8 to the sodium that was calculated on the lab, right? In this case, I think the sodium was 130 and we added the 8 to the 130 and it gave us 138. And so in fact, the sodium was not low, it was normal. It's just a falsely low due to the glucose being so high. Does that make sense?
Yes, sir. Thank you for the clarification.
Yeah, no problem at all. I know sodium is a pain in the ass, honestly. It's super complicated to manage. All right, cool. Well, I've got about 9:30. So how about I see you all back at 9:45. Okay, welcome back, everyone. We're moving into 9:45. We're going to pick back up. All right. Are there any questions before we move on?
No, sir.
All right. We go into note sharing here. Sure you all can see that. All right. Shut my video down. All right. So now what I want to do is I want to talk a little bit about cell and tissue adaptation. So last week we talked a little bit about oxidative stress, reactive oxygen species, and we'll talk and we'll harken back to that a little bit. But what I want to do is I want to take a bigger, kind of a larger look or bigger picture look at what happens when cells and tissues get placed into stress, essentially. So when we place cells and tissues under stress or adversity, what can happen? They can change in several ways, and we'll talk about some of those ways. All right. So the first way, in no particular order, is something called atrophy. So atrophy is where you get a decrease in cell size. This is important. The size of the cells decrease, but the number of cells does not. Okay. So the cells are still there. It's just that their cellular compartments become smaller, right? They lose mass. Right? Where do we see this? We tend to see atrophy when something is not being used. All right. We often see this, say, on extremities, for example. If you have a musculoskeletal injury and you have sustained immobilization, what happens? Well, you have a lot of muscle mass, right? And atrophy is very common when we see this with muscles. Muscles aren't being used. And we can see some age-related changes as well. And we can also see this in the nervous system, for example, the brain. We can see some atrophy occurring in the brain. With normal age, the brain will shrink a little bit. And certain pathological conditions can cause atrophy as well. Certain neuromuscular disorders where the nervous system cannot cause muscular contraction, right? You can see lots of atrophy. Think of various motor neuron diseases like alatotrophic sclerosis, or ALS, Lou Gehrig's disease, where you have a loss of upper motor neurons. You're going to get atrophy of muscles that are not being used, and this eventually leads to at a loss of the ability to use respiratory muscles, the diaphragm and the intercostals, and people can't breathe anymore, need to be on a ventilator, and tend to end up dying of respiratory infections. So there are lots of situations where atrophy can occur. All right. And then that is kind of the opposite of something called hypertrophy. And hypertrophy is the opposite of atrophy. This is an increase in cell size. All right. So it's not an increase in the number of cells, but it is an increase in the size of the cells. And as you might imagine, this tends to be very common in the setting of muscles. When muscles get used a lot and placed under stress and have to work a lot more, they will increase in size. Muscle cells, myocytes, tend not to divide. And if you lose muscle, you tend not to get that muscle back if you lose the actual cells. Like if there's an injury, for example, you tend not to get those lost cells back, but the remaining cells can undergo hypertrophy. We also see this with the heart. And when the heart is put under stress, you can actually have an enlargement of the heart. And a common issue that we see is something called LVH, or left ventricular hypertrophy, where the left ventricle of the heart enlarges. And this is common in people as they age. And it is very common in people that have hypertension, elevated blood pressure, because the left ventricle is having to work harder. That's what we call the afterload, to push blood out, right? The afterload in the arterial system is very high, and so the left ventricle have to work, and the left ventricle will undergo hypertrophy. And a certain amount of hypertrophy can be okay, but what can happen is if you look at a cross section of the left ventricle, something like this, if you have severe hypertrophy, what can happen is the muscle mass can get so large that you lose the volume of the left ventricle. So you can see that the muscle mass is so large, there's so much hypertrophy here, that the volume of the left ventricle has decreased. And so the cardiac output is decreased as a result of that loss of volume. So what we call the stroke volume is decreased, right? And so left ventricular hypertrophy in some cases can be a component of heart failure, we call congestive heart failure. Left ventricular hypertrophy, among others, can be associated with that. So that's hypertrophy. Another one that can happen is hyperplasia. Hyperplasia is where you have increase in cell division. So that is to say that cells are dividing, right? And so the number of cells is increasing as opposed to the mass of the cells or the size of the cells, right? Hyperplasia is cell division, right? And we see this in areas where you have lots of cell division in your body, specifically in the skin, the integumentary system, all right? And we can also see this pathologically. A common area is in the prostate. And there is a disorder very common known as BPH. And that stands for benign prostatic hyperplasia, which is where you have increase of cell division of the cells in the prostate, and the prostate begins to enlarge because there are now more cells. There's more cell division. And this is very common in people as they age. Typically after about 35 is where you start seeing this occur. But you can see this occur in other areas of the body as well. If you have lots of friction or stress, that can induce hyperplasia in tissues where cell division can occur. All right. Another thing that can happen is something called dysplasia. Dysplasia is essentially where you have an alteration in the size, shape, organization. Essentially what you get is you get irregular or abnormal changes in these cells. All right, that's dysplasia. So it's abnormal, it's irregular. All right. And oftentimes this can actually be what we call precancerous when we have dysplasia occurring. And an area where we see this, I'll give you an example, is where you have chronic irritation or inflammation. And an area where we can see this is the esophagus. In somebody who has reflux disease, like acid reflux, or they have a hiatal hernia, or they have something called GERD, gastroesophageal reflux disease.
Chris, you said it.
Constant reflux, stomach contents into the esophagus will cause sustained irritation and inflammation of the esophagus, and a certain kind of dysplasia known as Barrett's esophagus can develop. And Barrett's esophagus is precancerous, and a large percentage of these people, like 10 or more % of these people with Barrett's esophagus, will go on to develop esophageal cancer. Right? That's the problem with dysplasia. We can also see this in the cervix. Right? You can see dysplasia of the cervix. Typically, that's due to a viral infection, the human papillomavirus, and that can increase the risk of a cancerous lesion developing as well. Another one is something called metaplasia. And metaplasia is essentially where one cell type is replaced by another. For example, if you have like fibrotic changes, this can happen in the lung or the liver, other organs. Fibrotic changes, right? That is to say that the normal lung tissue is being replaced by non-functional fibrotic tissue. That would be an example of metaplasia. You can get this in epithelium, and remember, epithelial tissues cover surfaces. A common place is in the respiratory tract, or the respiratory epithelia. For example, people who are smokers or get exposed to large amounts of pollutants, what can happen is you can get the regular mucosal epithelial lining, the columnar, the pseudostratified columnar epithelial tissue of that lines the respiratory tract can become metaplastic. And so you have one cell type gets replaced by another, and oftentimes that replacement is its function is very different, or it doesn't function well at all. And then what can happen is you can also get something called neoplasia. And neoplasia, neo means new, so it is new abnormal growth. And this is often what leads to the development of something called a neoplasm. Does anyone know what the common term is for a neoplasm? New abnormal growth of tissue.
Cancer or a tumor?
Yeah, tumor. Yep. Yep, that's what a tumor is. Tumor is a neoplasm. So a tumor is kind of an extreme case of cellular adaptation. And typically what you get with tumors is you get multiple adaptive changes, right? So you get cells that are undergoing hyperplasia. So you have increased cell division. These cells tend to be dysplastic, metaplastic, and when you get these things occurring at the same time, that can lead to neoplasia, new abnormal growth. You get a tumor, and there are two major types of tumors. They're what we call benign tumors, and they're what we call malignant tumors. And what is the difference between a benign versus malignant tumor?
The malignant has blood flow through it.
Both of them.
One stays
blood.
One stays put, the other one spreads.
Yeah, and both can get large, right? So both grow, both can get large, but a benign tumor, right? It stays in the area where it originated. So it stays in its origin, right? So a benign tumor will not spread throughout the body. Now, a benign tumor can still be life-threatening, right? If you have a benign brain tumor, that just means that tumor is going to stay in your brain, but as it gets larger, it can still put pressure on critical areas of the brain and cause problems. So benign tumors are not necessarily without problem. It's just that they do not spread beyond their origin, whereas malignant tumors can spread to other areas of the body. And when that happens, that is referred to as metastasis. Metastasis is where a malignant tumor spreads to other areas of the body, different lymph nodes, and to different distal areas, right? Lung cancer spreading to the brain, for example, right? That would be a malignant cancer. All right. So there you go. That's just a basic introduction to those concepts. So now what I want to do is I just kind of want to move on, and we're going to just kind of stay bigger picture here. And we're going to talk about some types of injuries. And essentially an injury is where you go beyond just stress, or the stress or adversity causes problems. It causes a marked dysfunction of the cellular process, right? And this is what a cell injury is. And so we talk about cell injury. Lots of things can injure the cells. And I'm just going to give you some common examples. One of the most common is hypoxia, right? A lack of oxygen. Either you can't circulate oxygen to the cells, or you can't get oxygen into the blood to circulate it, right? There are many things, but hypoxia is a very common cause of cell injury. So hypoxia is a lack of O2 to the cells. And then another concept, which is very common, it is similar to hypoxia, but not quite the same thing, is ischemia. And ischemia is where you have a decreased blood supply. And sometimes ischemia can lead to hypoxia, but not necessarily. You can have a decreased blood supply, but so you can have ischemia, but you might be able to get adequate amounts of oxygen to cells or tissues, right? But then maybe those tissues are put under increased workload, and then those ischemic tissues have become hypoxic. So ischemia and hypoxia are related to some extent, but they are different processes, right? You can have chemical injuries, right? Think of overdoses, infectious injuries. You can have the immune system. Often this is due to prolonged inflammation. And sometimes this can even be due to what's known as a hypersensitivity reaction or an autoimmune disorder. We'll talk about those in some detail later on. You can have physical, right? Think of trauma, traumatic injury, right? And I mentioned just the damage due to prolonged inflammation, right? So these are some of the kinds of cell injuries. Hypoxia is incredibly common. Often it's be very deadly because it's an ATP issue, right? Cells not produce ATP or adequate amounts of ATP. And we talked about what happens when cells cannot produce adequate amounts of ATP, right? There are lots of things that happen there, right? The ion channels fail, the cells begin to swell. They can't power themselves. You get typically you get acidosis that develops due to a buildup of lactic acid, right? So there are hypoxic, ischemic, acidotic, swelling cells, and of course that can lead to death ultimately. All right. Okay. And we will talk about some of these injury patterns in a little more detail in some additional lectures. I'm actually going to talk about infections is their own thing. And we'll talk a little bit about bacteria and viruses and a little bit about how they're classified and some of the major ones that we run into. So I just wanted to kind of mention those. But I do want to spend a little bit of time talking about hypoperfusion and shock. All right. So first of all, let me ask the question, is there a difference between hypoperfusion and shock?
Doesn't shock come from hypoperfusion?
Yes.
Yeah, they're definitely related, but there is a difference. So hypoperfusion, let's just talk about that first. So hypoperfusion is just that, right? When tissue perfusion decreases below normal, right? So you have a a decrease in perfusion to the tissues, to cells and tissues. And what happens in hypoperfusion is the body's response is what's called shock. So think of shock as the body responding to hypoperfusion. So often we say that shock is not abnormal, right? Shock is rather a normal response to an abnormal situation, right? So think of hypoperfusion as the problem, and shock is what the body is trying to do about that problem, right? So shock is a way of compensating for hypoperfusion, all right? And there are lots of things that can happen with shock, and I'll just briefly mention them in general, right? So one of the first things that happens is the sympathetic nervous system is activated, right? And that causes a release of epinephrine and norepinephrine. What does that do? Well, that acts upon beta receptors, specifically beta 1 receptors in the heart, and that increases the heart rate, increases stroke volume. And then you have epinephrine and norepinephrine acting upon alpha, specifically alpha 1 receptors in the blood vessels, and that causes vasoconstriction. And what does that do? Well, that shunts blood from the periphery to the core of the body. So blood gets shunted from the periphery to the core, right? And that shunting of blood and that vasoconstriction may act to increase the blood pressure as well in an attempt to correct that hypoperfusion. So that's one thing that happens. The other major thing that happens is an activation of a hormonal system known as the renin angiotensin aldosterone system, or the RAAS. I'm going to talk about that in just a little bit of detail because it's very important. It is an important example of something called a negative feedback. A negative feedback system. And negative feedback loops are critical for all biological systems, right? Or complex biological systems, right? And essentially what negative feedback is something happens that may cause a problem. The body attempts to fix a problem, and when the problem is fixed, that shuts the system off. That feeds back into the system and shuts it off. And so a basic example of this would be you get in your car, you turn your car on, and what happens? Well, the first thing that happens is you get a dinging, right? So that dinging, that ding or that ring is your car telling you, hey, you could potentially die in a traffic accident. So what do? Well, it prompts you to buckle your seatbelt. And what happens when you buckle your seatbelt?
Goes away.
Yeah, the act of buckling your seatbelt feeds back and it shuts the ringing off. So that is a very basic example of a negative feedback loop, right? Your seatbelt alarm. So the renin angiotensin aldosterone system is also activated. And this is a system that kind of starts with the kidneys. So I'll just draw a little kidney here. And what happens is when you have hypoperfusion, one of the most sensitive organs to hypoperfusion happens to be the kidneys. So the brain, the heart, and the kidneys are some of the most sensitive organs to hypoperfusion. So what happens is you have a decrease in renal perfusion, And the kidneys realize that, and what they do is the kidneys secrete a hormone, called renin. All right. And what that renin does is that renin interacts with a molecule floating around in your blood. All right. Called angiotensinogen. Angiotensinogen. And the renin converts the angiotensinogen into angiotensin 1. And then the angiotensin 1 circulates through the lungs, where an enzyme in the lungs called ACE is created. So angiotensin 1 encounters ACE. ACE stands for angiotensin converting enzyme. And that converts angiotensin 1 into angiotensin 2. And angiotensin 2 causes vasoconstriction. So it causes additional vasoconstriction on top of what you're seeing with the alpha-1 effects to try to increase the blood pressure. Additionally, you have from the brain, you have a hormone called aldosterone. And the aldosterone's released, and it causes you to hold on to water. And hopefully that increase in fluid volume will increase blood pressure and increase perfusion. And when blood pressure and perfusion increases, right, that feeds back into the kidneys. And when the renal perfusion increases, they quit secreting renin, and this system then shuts down, right? That's the negative feedback. If not, then more and more happens. There are certain of hypoperfusion states where this system actually becomes pathologic. For example, in the setting of congestive heart failure. If someone has an exacerbation of their congestive heart failure, what happens is their sympathetic nervous system gets activated, and the renin angiotensin aldosterone system gets activated. And the problem with that is the vasoconstriction, the increase in blood coming back to the heart, can actually be harmful because the heart's not working well, right? And so essentially what you're doing is you're vasoconstricting, you're activating the heart to tell it to beat harder and faster, and you're pushing more fluid back into the heart. And if the heart is failing, you can see that this will do what? Well, this will cause the heart to fail more. And then as the heart fails more, you get lower renal perfusion, and you get more of this, more vasoconstriction, more sympathetic nervous system activation, and this becomes a vicious cycle that can lead to death. And so a part of treating congestive heart failure is interrupting these pathways. And that's why, for example, ACE inhibitors, angiotensin converting enzyme inhibitors that inhibit the ACE enzyme in the lungs, are an important part of this, right? That's why beta blockers are sometimes used as well, right? To block that. Diuretics are sometimes used to get rid of the excess fluid that's leading to the heart failure. So sometimes the very mechanisms that the body employs to fight hypoperfusion can actually be problematic, such as what we can see with congestive heart failure exacerbations. And we actually have to interrupt those pathways. But with that in mind, let's just talk about the general types of shock. All right. So there are a couple of different major types that we call central and peripheral shock. So remember, shock's how the body is responding to hypoperfusion. So you've got central and you've got peripheral. And this kind of has to do with the kind of hyperperfusion that is causing, right, problem. All right, so central and peripheral. So central shock is really to a shutdown of the central mechanisms that pump blood around the body. So think of this as the heart failing. So this is a heart problem. All right. Or think of this as an obstruction. Oops. All right, an obstruction of perfusion. So cardiogenic shock and obstructive shock are the major examples of central. And obstructive shock tends to be due to things like tamponade. Does anyone know what tamponade is? Pericardial tamponade specifically. Does everyone know what that is?
Fluid accumulation in the pericardial sac of the heart.
Good. So fluid accumulates around the pericardium. Good. All right. And then that puts pressure on the heart, specifically blood coming into the right side of the heart from the venous system. That's called preload. And the heart can't get preloaded, and then the cardiac output falls, right? So tamponade is one major example of obstructive shock. The other major example is a tension pneumothorax. And this essentially does the same thing, is it puts pressure on the low pressure venous system, the blood coming back to the heart. So blood can't go into the heart, into the right side of the heart, and the heart loses its preload. And then you have a loss of perfusion there, right? So those are kind of the major types of what we call central shock, all right? Cardiogenic and obstructive. And obstructive often is either a tamponade or a tension pneumothorax, all right? But let's move on and let's talk about peripheral shock. So peripheral shock is where you have the peripheral blood vessels, all the stuff outside of the heart, all right? All the stuff that does not directly act on the heart, but certainly indirectly does, all right? And this really comes down to two major subcategories. You have what's called hypovolemia. Hypovolemia is just a loss of volume, and that could be due to dehydration, could be due to hemorrhage, could be due to excessive vomiting or diarrhea. And then you have something called distributed shock. And this is where you're not necessarily losing fluid, but fluid is being distributed to other areas of the body. For example, fluid within your blood vessels is going somewhere else. Or your blood vessels have become larger than normal. You have what's called vasodilation. All right, so some examples of things that can cause an abnormal distribution of blood flow include things like anaphylactic shock. All right, where this is an immune modulated, and we will talk about this in a little bit of detail in immunopathology at the end of the week. Anaphylaxis. You can get septic shock, right? Where you have toxins released typically by bacteria that cause vasodilation. All right. You can have something called neurogenic shock. That is a failure of the central nervous system, right? A loss of the sympathetic nervous system. And so the sympathetic nervous system is no longer able to act on the blood vessels that cause them to constrict, and to act on the heart in some cases and cause it to beat at a normal rate. So you get vasodilation, you can get a lowered heart rate, right? And so these are the major types of shocks: central, peripheral. Remember, central is due to failure of the heart or obstruction, and peripheral is hypovolemic and distributive, right? So that's just kind of a way of conceptualizing shock. Right. All right, is everybody okay there on shock and what it is and how it is related but different from hypoperfusion?
Yes.
All right. Well, let's see. It is 10:22, so we're getting close to 10:30. I think we'll go ahead and just take another break. How about I see you all back at 10:37? 10:37. All right, welcome back, everyone. All right, so we'll go ahead and finish up talking a little bit about what happens to cells that have undergone some sustained stress, hypoperfusion, and what can kind of go on when a cell is damaged, and it is perhaps damaged to the point where it just can't function normally anymore. And there are really two things that can happen. Both things lead to the ultimate outcome for the cell is similar, but the pathophysiological processes are different, and the overall issues that we see at the larger scales tend to be very different as well. And these are these are what we refer to as apoptosis and necrosis, right? And this is essentially how cells die. These are the two major ways that cells die: through apoptosis or through necrosis. And we'll talk about them, and I'll give you some examples, and we will just get the terminology down. So what I'm going to do is I'm going to switch over to the screen here, and we will compare, contrast, differentiate, and talk a little bit about apoptosis and necrosis. All right, so apoptosis and necrosis. So first of all, let's just get an idea of what these are. So apoptosis is also referred to as programmed cell death. This is essentially when cells undergo suicide. They essentially kill themselves. But the thing that I want you all to remember is apoptosis is regulated. This is regulated, and this is orderly. And when this occurs, this is not typically associated with inflammation. All right, it is not associated with inflammation. And so what happens is it is regulated. There are different protein systems. Based proteins play an incredibly important role in regulating this orderly shutdown, and you begin digesting and breaking up. You begin catalysis or catabolic reactions that chop things up. And then you get these little blebs and bulges that form, and then they shrink into what are called apoptotic bodies. And then those apoptotic bodies are engulfed by neighboring cells. Okay. So what you get is you have your cell here, and maybe something happens to it. Maybe it is damaged. Maybe it's just gotten old, or maybe it needs to be replaced. Whatever the case may be, right? It receives a signal, and oftentimes is from the immune system. And there are special cells in the immune system called cytotoxic T cells. And those cytotoxic T cells, excuse me, can signal for that. Or sometimes the signaling comes from within the cell itself. Oftentimes is the mitochondria where this will begin, right? So this can be intrinsic and extrinsic to the cell, right? And so what happens is the cell kind of begins to shrink down as it starts chopping up its components. So you get what's called condensing of the cell. So it shrinks down, all right? And then what happens is, as it chops things up, it breaks itself down into these little fragments, all right, that have stuff in them. And then those fragments get reabsorbed into the neighboring cells, all right? And sometimes apoptosis is normal. We actually want apoptosis. For example, when in normal neonatal development, the baby, their hands will be webbed. So you get webbing in between the digits. And as that baby develops, apoptosis occurs and the webbing goes away. And you can have the digits are individual. And sometimes when apoptosis does not occur during fetal development, those babies will be born with that webbing intact, right? That's just one example of where you actually want apoptosis to occur, all right? Typically, apoptosis is not going to be as bad from a pathophysiological standpoint as necrosis. So oftentimes apoptosis is fairly normal, and it is often not overtly pathological. So when you have cell death, this is the kind of cell death you want to have is apoptosis, right? And that is a little different from what's called necrosis. So necrosis is always pathological. It is always abnormal, right? If necrosis is occurring, this is abnormal, and there is no good reason that necrosis should be occurring. So in necrosis, what you see is it is not regulated at all. It is very disorderly, right? So it is premature death. The cell did not anticipate this, and it is due to disruption of cell function. Oftentimes, it is due to injury, hypoperfusion, right? And then what you have is you have a decrease in ATP production, and you have oxidative stress. All right. and the cell is no longer able to function, right? It loses its functional control. It's destabilized, all right? And what happens is, as remember we talked about last week, as ion channels fail, the cell begins to take on water, right? Begins to swell, and then it ruptures and disintegrates. All right, so here you have the cell, nucleus, mitochondria, and some other organelles. And so the cell begins to take on water. And then what happens is it ruptures. And then it releases its contents out into the external environment in an unpredictable, chaotic manner. And then that triggers the immune system. And phagocytic cells begin moving in. And then you have a substantial inflammatory response. All right. So you can see this is very different from apoptosis, right? So that's necrosis versus apoptosis. So a way to think about this is think of a sumo wrestler. Think of a sumo wrestler, right? So let's have necrosis versus apoptosis. All right. So the S is size. All right. So necrosis, you get swelling of the cells as ion channels fail, right? Many cells are involved as well. Large numbers of cells tend to be involved. Now, with apoptosis, you tend to get shrinkage of the cells. And apoptosis is very individualized. It's the individual cell, right? Okay, you're faulty. You need to go kill yourself, essentially, right? Is what's going on. And so it is limited numbers of cells. It may even be one cell, or very limited. All right, so that's size. U is uptake. All right. So in necrosis, what happens is because the cells swell and rupture and release stuff out into the interstitial environment, you have to have inflammation, right? This causes inflammation, which means macrophage move in. So phagocytic cells move in. So you have a substantial activation of the immune system, right? Those phagocytic, the macrophages or the monocytes move out of the bloodstream and become macrophage. In apoptosis, what do you have? Well, you have neighbor cells. The neighbors ingest, right, the cell contents that are all packaged up nicely. And so there is no inflammation that occurs. So that's the uptake, right? Let's talk about the membrane. The cell membrane, that's the end, all right? So in necrosis, you have a loss of integrity. The membrane ruptures and you have lysis of the cell. And it spills its guts all over the place, right? Whereas you've got blebs that form and pinch off, but the membrane remains intact. And this, of course, are what we call apoptotic bodies. And then finally, the organelles. what happens to the organelles of the cell? Well, you tend to get swelling and lysis of the organelles, right? And you have DNA degradation with necrosis, whereas in apoptosis, right, the mitochondria release proteins like caspases that help condense and package the organelles and their contents, right? And you have a very orderly breakdown of cellular DNA. All right. So that's sumo, just kind of thinking about comparing and contrasting apoptosis and necrosis. All right. Now, with that in mind, because necrosis is always pathological, there are different kinds of necrosis, and there are different pathologies that tend to be associated with these kinds of necrosis. So what I want to do is I want to talk about some of the major types of necrosis, all right, and then give you a few examples. All right, so let's talk about necrosis specifically, or the types of necrosis. All right. So there are 3 or 4 like canonical necrosis, and then there are a couple of others that are combinations of. So what I want to do is I want to talk about the major types of necrosis, and then we can talk about some of these more specialized things. So let's talk about the major patterns of necrosis. So one of the most common is what's known as coagulative necrosis. Coagulative necrosis. All right. Coagulative necrosis is where the underlying architecture of the tissue is maintained. All right. So kind of like a house, right? If the skeleton, right, you can have a house breakdown, but maybe the skeleton of the house remains intact, but everything else is gone, right? So with coagulative necrosis, you have the underlying architecture remains. The bulk of the tissue, goes away. All right. And so you have what's called coagulation occurring. And this kind of necrosis is very commonly the result of ischemia that leads to death. And when you have an area of dead or necrotic tissue where the architecture, the frame of it is still there, but all the rest of the stuff is gone, this is often referred to as an infarction. For example, if you have a myocardial infarction and you kind of have a scarred area of the heart that no longer works, that is where coagulative necrosis has occurred. And we see coagulative necrosis occur in organs like the kidneys, the heart, the adrenal glands, sometimes the liver as well. All right. And so this is often the result of ischemia and hypoxic, or ischemic and hypoxic injuries, often cause coagulative necrosis. Now, that is a little different from another type of necrosis known as liquefactive necrosis. So liquefactive necrosis is where you actually have digestion of dead cells. So you get a liquid, and oftentimes this is sometimes referred to as pus that forms. All right. And so this is often seen in the setting of an infection where you get liquefactive necrosis occurring. All right. The only area where hypoxia caused liquefactive necrosis, and we don't know why this is the case, but there's one area of the body where hypoxic and ischemic injuries will cause liquefaction, and that is in the central nervous system. So in the central nervous system, the brain primarily, if there is ischemia or ischemic / hypoxic injuries, instead of coagulative necrosis, you will get liquefactive necrosis. All right. That's kind of unique there. All right. The next type of necrosis is something referred to as caseous necrosis. Caseous necrosis is a bit esoteric. It's a very specific kind of necrosis. And it is essentially a combination of coagulative plus liquefactive. Think of it as a combination of those two. And we typically only see this in one specific instance. It shows up in other places as well. And caseous, just think of is cheese-like. In fact, that's where part of the name caseous comes from. And we tend to see this with tuberculosis infections, with mycobacteria tuberculosis. All right. So these are the three major types of necrosis, and then there are a couple of other types that are not technically their own types of necrosis. They're special cases of these three types. So let's talk about the special cases. The first is something called gangrene or gangrenous necrosis. And gangrene is actually just a type of coagulative necrosis. And it is a type of coagulative necrosis that occurs when an entire limb loses its blood supply for an extended period of time. So essentially what you get is you get coagulation of large tissue planes. So you have occurring in the muscle, the nervous tissue to some extent, the subcutaneous tissue, and so on and so forth, right?
So would it be
and this
related?
Is what we call gangrene. Oh, I'm sorry, go ahead.
Would it be related to like frostbite?
Yeah, frostbite is something, yeah. So frostbite, that's a good example of this. With frostbite, you have a freezing injury, you have a loss of blood supply, and then instead of just a small area, like a myocardial infarction is a specific area of heart infarcts, you have infarction of possibly the entire limb, right? And it can be just, a finger or a hand or a whole limb, right? But you have multiple planes of tissue involved, right? And with that, typically, as long as there's no infection in the setting of gangrenous necrosis, which is often the case with frostbite, then you'll kind of get a dried out, blackened, and even a quote unquote mummified appearance to that dead tissue, to that necrotic tissue. Now, sometimes what will happen is you will have an infection that will also occur. So if you have gangrene occurring with an infection, then you're going to get something a little different. You're going to get not a dried out mummified appearance, but you're going to kind of get a wet, possibly swollen appearance. All right. And that is sometimes referred to as wet gangrene when you have an underlying infection. And if the organisms, the bacteria typically create lots of gas, you can get gas bubbles developing, and that is referred to as gas gangrene. Right? So yeah, frostbite is a good example of that. Sometimes we can see this with diabetics. We know that chronically elevated blood sugar is very toxic to blood vessels, and they lose the blood supply to their distal tissues, and they can develop gangrene. Oftentimes, they will develop more of the wet type of gangrene, though, because there's often an infection, a bacterial infection involved with that. And so that's gangrenous necrosis. It is a special type of coagulative necrosis. And the last type of necrosis that I want to mention is something called fat necrosis. All right. And essentially what happens here is you have lipase proteins get activated. Oftentimes this involves the pancreas, where you have lots of lipase enzymes. And then essentially it starts digesting fats. And then that causes the pancreas to become inflamed as well. And that's a condition as pancreatitis. All right. And you get kind of get a liquefaction that occurs. All right. So it looks somewhat similar to liquefaction necrosis, but it is primarily the fat that is breaking down, that is necrosing the adipocytes or the fat cells. All right. And those are some of the major things that we see with necrosis. Again, this is all when cells die abnormally. Right. So, are there any questions over any of that? Anybody have any questions? Excuse me. Okay. Well, if there are no questions, and I think what we'll do is, since I know you all have some homework assignments due by this evening, I want to give you a little extra time to work on that. And so I think what I'll do is, if there are any questions, we'll go ahead and conclude the lecture here. Tomorrow, we will focus on some additional concepts. We're going to focus primarily on talking about sepsis and septic shock, as well as a multiple organ dysfunction syndrome, or MODS, sometimes referred to as multi-system organ failure. and we will talk a little bit about pathogens, bacteria, and viruses, and some of the terminology there. And I'll also talk about another lab test referred to as the CBC, or the complete blood count, and a little bit about cancer and cancer terminology as well. So with that in mind, are there any questions about anything we've covered today?
Nothing here.
All right. Hopefully today was maybe a little more laid back on the material, on the content, not quite as rigorous as the last couple of lectures.
Hey, Chris, are you referring to the pathophase, not pathophase, the acid base and advanced acid base and electrolyte and fluid assignments due tonight?
I thought there was today's the 15th, right?
Yes, sir.
So I thought there was a pathophysiology chapter summary that was due today. Yeah.
Oh, it is due today. I'm sorry.
Yeah. So I just want to, and I just wanted, and that's worth 20 points. So it's a big assignment. So I wanted to give you all the a little extra time to make sure that you get that done. But all the homework assignments are already due. I just need to get everything graded for you all. Yeah, so it looks like chapter 9 summary is due, and then chapter 10 will be due next week. Yeah. All right. Any questions?
Negative.
All right. Well, let's wrap it up. A little early, but I'll give you all some time to work on stuff if you need to. Well, I will see you all in the morning.
Good. Thank you, Chris.
Have a good day.
Thank you all so much.
Thanks, Chris.